15 minutes or so, give or take. 15, 20 minutes, and then 5 to 10 minute discussion.
Right. Okay. Well, the one time I timed it, I've made changes since then. It was like 19 minutes or something, so I haven't timed it since then.
Yeah. So it seemed like, I know once you're there, you kind of, start to talk a little bit faster. You start to feel a little bit rushed. And so they haven't docked anybody going under 30 minutes, nor I haven't really seen anybody go over 30 minutes either. So
okay.
I don't think that part really matters. All right, Miss Jenny, you're up. We are officially recording.
Okay. Where's my share screen? Okay. Okay. Hello, everyone, and thank you so much for joining me as I present my quality improvement project entitled Improving Sexual Health with Effective Care at a Federally Qualified Health Center. This is a picture of our team when we first got started back in November of 2018. Every year in the United States, approximately 20 million sexually transmitted infections occur, 3 million women experience an unintended pregnancy, and 210,000 babies are born to teenagers. More than 260,000 women will be diagnosed with breast cancer, and over 4,000 women will die from cervical cancer. These poor sexual health outcomes cost the nation billions of dollars annually and have become a national health priority. The state of Oklahoma has the third highest teen birth rate in the country, and according to the CDC, has seen a significant and steady increase in STIs, including gonorrhea and chlamydia, since 2013. According to the National Cancer Institute, breast and cervical cancer rates are stable throughout the nation, but continue to rise in Oklahoma. A review of 20 well woman visits from the Women's Healthcare Clinic at NEO found that while we were 100% compliant with breast and cervical cancer screening and addressed contraception 92% of the time, we only addressed STIs 50%, and we did not address HPV vaccination at all. Based on this analysis, HPV vaccine uptake was the original project focus. However, once we started, we realized that the chart review did not look into OSIS, the state-required database for immunizations, and therefore the gap was less than originally thought, so we expanded the project. We implemented an evidence-based sexual health bundle consisting of HPV vaccine uptake, STI screening and testing, safe sex education, utilization of contraception, cervical cancer, and breast cancer screening. Sexual health is a national health priority, and despite efforts focused on wellness and prevention, the United States has some of the poorest outcomes in the world. Preventive care has been shown to save millions of lives as well as billions of dollars annually and is recommended by national organizations. A 2014 study of 14,000 patients showed that only 50% of patients 18 years and older received the recommended preventive care between 2007 and 2010. So in 2016, ACOG launched the Women's Preventive Services Initiative and provided evidence-based recommendations, which included immunizations, management of infectious disease, reproductive life planning, and screening for and management of chronic disease and cancers. The Institute of Medicine defines effective care as providing services based on scientific knowledge to all who could benefit, therefore avoiding underuse, and refraining from offering services to those not likely to benefit, overuse, and misuse. Right care has multiple facets and considers patients' values, the incorporation of shared decision-making, and the elimination of under, over, and misuse. Our gap analysis revealed an underuse of preventative services and a lack of shared decision-making. We used an SBIRT model for the project: screening, brief intervention, and referral to treatment. This model was originally developed to decrease alcohol misuse, but has been shown to be a valid model for universal screening. With these concepts in mind, we implemented a right care bundle of preventive services. The aim of this quality improvement project was to improve the screening and management of sexual health and gynecology patients at NEO Women's Health Clinic to 65% within 90 days. NEO Health System is a federally qualified health center in rural Oklahoma comprised of 11 clinics in 4 counties. And according to Mr. Rosenthal, our CEO, we had over 57,000 patient visits last year. This project involved an average of 268 GYN patients at NEO's Women's Health Clinic. The clinic itself has 3 physicians, 2 advanced practice nurses, 3 direct service representatives as front staff, and 3 medical assistants. The medical assistants and DSRs may float from one clinic to another, so NEO encourages standardization of forms and processes in an attempt to decrease error and improve efficiency. Our clinic sees an average of 150 patients per week, and the 2 participating APRNs with 1 MA see about half of the total gynecology patients. The patient population is primarily white women with a high school education or less on Medicaid, with a median income of $31,000 per year. The framework for the project was an 8-week rapid cycle quality improvement project utilizing 4 plan, do, study, act cycles. Each 2-week cycle introduced a new test of change to 4 distinct interventions. The interventions based on the SBIRT model consisted of screening with a pre-visit chart prep checklist tool, brief intervention for patient engagement with shared decision-making tools regarding sexual health, referral to treatment with a case management log to track right care, and daily team huddles to encourage team engagement. Throughout each PDSA cycle, interventions were studied for efficacy. Data was collected daily from the pre-visit screening and decision-making tools, chart audits, and the huddle agenda. Weekly team evaluations were conducted to evaluate team engagement. These results were entered into an aggregate data spreadsheet and plotted on a run chart. Data was analyzed every 2 weeks to note shifts, trends, and runs and drive the iterative process. To ensure reliability and validity of the data, operational definitions for process and outcome measures were developed and adhered to. Utilizing replication probability statistics, data from interventions based on the operational definitions were collected and plotted on run charts, which allowed the data to be represented in a time-ordered sequence. Again, this was analyzed every 2 weeks to identify signals, shifts, trends, and runs. Qualitative information from patients and the team were compared with these quantitative results to ensure consistency and identify common themes. After 14 data points were entered, we were able to assess for patterns of common cause versus special cause variation. And this is how we were able to determine if our tests of change actually caused the changes in our outcomes. This is where I say that this doctoral project was excused from review by the Institutional Review Board at Frontier Nursing University because it does not qualify as human subjects research and meets federal requirements for quality improvement, and no outside funding was received. This slide represents the results of our operational definition, process, and outcome measures. In summary, this top graph represents our aim to improve the screening and management of sexual health to 65%. This goal was achieved and we surpassed it. A balancing measure of visits, defined as the time the patient was called from the waiting room until checkout, was monitored and remained unchanged at 38 minutes. The bottom 2 charts represent our process and outcome measures, all of which showed improvements. Due to the desire for uniformity across all sites, the original pre-visit screening tool lacked applicability to our GYN patient population and was therefore only utilized 50% of the time and only included 35% of the pertinent data. So for our first intervention in cycle 1, January 15th through the 24th, was to modify the tool. And now remember, it was during this time that we realized the need to access OSIS, the state database for immunizations, and our scope was expanded. So during cycle 2, January 28th through February the 8th, the expanded sexual health information was added to the tool, but we continued to see a low utilization and therefore low identification of sexual health gaps, especially related to STIs. So during cycle 3, February 12th through the 21st, in an attempt to identify the cause of low utilization, the QI lead also completed and reviewed the pre-visit screening tools and discovered another system, the hospital lab, that needed to be accessed in order to obtain their results. So working with IT, a specific place within the EHR was created to document all aspects of the bundle, with the goal of eventually eliminating the need to access these additional systems, overcoming this barrier and creating sustainability. As you can see in cycle 4, February 26th through March 8th, tool utilization achieved 100% and identification of gaps averaged 99%. Overall, these interventions led to tool utilization achieving a shift in data and an overall project meeting of 94%. Identification of sexual health gaps had a positive trend, also showed a shift in data, and obtained a project median of 80%, 30% more than the anticipated goal. NEO had no standardized tools or processes to promote shared decision-making prior to project implementation. So PDSA 1, January 16th through the 29th, utilized a should I get the HPV vaccine shared decision-making tool that was modified from HealthWise, and both the tool utilization and perception of shared decision-making scored at 100%. After expansion to the sexual health bundle in PDSA 2, January 29th through February the 8th, a What Matters to You tool discussing sexual health recommendations was implemented. Tool utilization ranged between a high of 91 and an astronomical low of 33, with the addition of a second provider. Patients' evaluation of shared decision-making maintained a median of 99%. During cycle 3, February 12th through the 21st, we added open-ended questions to the post-visit evaluation about patients' willingness to change behaviors in relation to sexual health. Tool utilization improved to a median of 87, but shared decision-making again maintained a median of 98. While patients didn't indicate a willingness to change behaviors, neither the qualitative nor quantitative feedback indicated if patients felt they were truly participating in shared decision-making or simply checking boxes and leaving a good review for the provider. Part of NEO's branding is to give patients a Hershey kiss as a kiss goodbye with their checkout slip. In cycle 4, February 26th through March 8th, to incorporate this theme, when patients checked in, along with their health history questionnaire, they were given a Hershey kiss with a heart-shaped card asking them to kiss and tell your provider what matters to you. Tool utilization median was 89% and shared decision-making was unchanged. Despite these interventions, tool utilization throughout the project indicated only common cause variation, with a median of 86%, and patient scores of shared decision-making maintained the median of 98%, providing very little information. NEO also had no formal way to assess if patients were being offered right care as recommended by ACOG. Therefore, a case management log to track criteria was initiated and started baseline at 0%. After QIT meetings to define right care criteria, baseline data was collected and indicated right care was provided an average of 53% of the time. A second provider was added to the project at the end of cycle 1, January 15th through the 24th, and scores decreased from 89% to a low of 69. To motivate the second provider, one-to-one discussions were conducted and led to a stair-step increase, achieving a median of 88% by the end of PDSA 2, January 28th through February 8th. Cycles 3 and 4 indicated only common cause variation, despite the posting of a visual display board in cycle 3 and the addition of specific places to document the HPV vaccine status and STI screening results, as these were the specific areas lacking during cycle 4. Nevertheless, overall project data did indicate special cause variation with a shift in right care, and we achieved a project median of 94%, 30% above the goal. One of the biggest concerns for providers is lack of time, being asked to do one more thing during a visit that we already feel is not long enough. A balancing measure to track visit times, defined as the time the patient was called from the waiting room until checkout, was monitored, and times remained unchanged at 38 minutes. The key findings of the project include a 45% increase in the identification of sexual health gaps, and consequently a 53% increase in right care, for an average of 268 patients between 2 providers. One of the strengths of this project relates to its generalizability. The SBIRT is a validated model that can be utilized with any patient population. The pre-visit screening, Right Care Bundle, and the Huddle Agenda are evidence-based tools that are able to be customized and modified to any specific population or gap. Improvement in right care directly correlated with the pre-visit screening and evaluation of sexual health needs. A 2018 study had similar results when they initiated a pre-visit checklist and substantially improved reproductive health care with their patients. Studies and articles promoting shared decision-making can be found in almost every journal today. Therefore, the common cause variation of shared decision-making on patient engagement despite the interventions was a very surprising and unanticipated finding. However, a recent Cochrane review found that although shared decision-making is considered right care, evidence supporting use of interventions to increase shared decision-making is low. Nonetheless, the incorporation of what matters to you versus what's the matter with you was an impactful and positive practice-changing lesson for the providers. The identification of the need to access multiple databases leading to the creation of a specific single place within the EHR to document sexual health status was a significant impact of this project. This resolution did not immediately resolve the issue, but it does provide an improved process and over time will eliminate this barrier and achieve sustainable results in both identification and management of sexual health gaps. A possible limitation to the generalizability of the project is the differences among EHRs across settings. The primary success of this project was related to the identification and resolution of a very specific process barrier that may not be applicable in different sites. A second limitation may be there were only 2 providers and 1 MA involved in the actual implementation of a relatively short QI project. Finally, the project leader invested many personal hours into the motivation of the team and data collection. This time requirement may necessitate the need for a quality improvement specialist or allocating time to providers during the work week, both of which create a possible financial burden. The inability to confidently determine patients' participation in shared decision-making lends to possibilities for future study. However, this project does contribute to the body of knowledge that pre-visit planning and checklists improve patient outcomes, specifically outcomes related to sexual health. Maintaining the standardization of tools and processes created a predictable work environment while ensuring applicability to patients and contributed to the usefulness of the interventions while also remaining consistent with NEO's goals. The processes that led to these outcomes are now ready to be adopted by other clinics and specialty and serve as a model for other settings as we work towards improving sexual health in the United States. And these are my references. Any questions?
I thought you did a great job.
That was excellent.
Your project topic is so important.
Do what?
Your project topic is so important.
Good. Hopefully what I said made sense.
It did. You did a very nice job.
Now I'm really nervous to follow you.
I know. Now I'm like, gosh, I need to go redo my presentation.
Like, how am I going to memorize all that crap and not read it?
Just practice and it'll flow right along.
Yeah. I was gonna say, just remember you're talking to your coworkers who are your friends. It's a nice, relaxed environment. If you forget something, only you're gonna know it because they don't know the data like you know the data.
Yeah.
Also, you literally wrote the project.
Right.
Yeah.
Like you
So
don't
it's one of those. Yeah. So it's one of those where if you forget something, just move on, just keep going. And like Nicole said, you're doing a really good job. Really nice.
Thank you. Thank you. What did you guys think? I don't even know. Did you notice when I was doing the run charts where I kind of like ran my mouse over the dates? Did that help or was that distracting? It was very distracting for me talking. So I don't know if it helped anything.
I mean, if anything, you don't necessarily have to state your dates of when things were. It could just be like, okay, in PDSA cycle 1 we did this, in PDSA cycle 2 we did this.
Okay.
So dates don't really matter. I mean, to you, yes, they matter, but to your audience, we could care less as what time frame you did things. You could just, so you don't even have to remember, when did you start PDSA cycle 1? When you just talk about in PDSA cycle 1 we did this, and in 2 we did this, and in 3 we did this.
I asked Mike, and he's like, he wanted to know when the dates were and what does this mean, and so I was trying to be more specific and kind of lead the eye. But when I'm speaking and doing it, it was very distracting for me. And so it's like it's not helpful, then I don't want to do that.
Yeah.
Okay.
Well,
And I mean, it's like,
go back to what can you remember, or you know, like what do you feel like is going to be natural for you when you're speaking to everybody about each section?
Okay.
Yeah.
I really liked your results page. Sorry, I keep cutting you off.
No, you're fine.
I did too. I liked the bar graphs. That was very visually easy to follow.
Oh, good. On the measures, that one?
Mm-hmm.
Okay, good. I was really not sure how to do that because that's so much information that you don't want to just ramble on about. And so, good. I'm glad you guys like that. Good.
Yep.
Because I think,
go ahead.
if I'm not mistaken, we're not going to cover every single result and all that because everybody can kind of see for themselves. So just kind of hit the high points, which you did.
Okay, good.
Yep. And then, I mean, afterwards, like once she excuses the, online audience, if somebody has a more specific question about your data, you can go over it with them specifically if they have questions.
Okay, good.
So I do have a question. Are y'all sharing your handouts or anything with your in-person audience or just no?
I'm not.
Okay.
I wasn't going to.
Okay. Good. That makes me feel better.
Yeah.
Yeah. And I mean, if somebody has a specific question, they can come up. I mean, everybody at my site knows who I am. It's like they can email me or text me or afterwards say, hey, can you send me blah, 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 blah.
Mm-hmm.
Sure.
Okay. And while we were implementing the project, I would put run charts up on the bulletin board so they could see our progress too. So
yeah.
Hopefully that should be semi-familiar to them.
Right.
Yeah.
Okay, are y'all ready?
All right. Yep.
Okay. Let me share my screen.
Did anybody time that at all?
You were about 18, 19 minutes. So yeah, you were under 20 minutes, which is fine.
Okay, good.
And just know you're probably going to rush it a little bit on the day of.
I know, I tried really hard to go a little slower.
Yeah.
Okay, can you see my screen?
Yeah.
Okay. Hi, I just want to thank everyone for coming today to my presentation. My name is Nicole Wilson, and this quality improvement project was on increasing effective right care for adolescent well child exams and immunizations in a rural clinic. This is a picture of the kids clinic at Lifespan Health, where we conducted the majority of this project. In the West Tennessee, in the state of Tennessee, as you can see, there is a gap in care. When you look at the well child exams and the recommended immunizations for those in the 7 to 12 age group, which are human papillomavirus, Tdap, and a meningococcal vaccine. As you can see, we fall behind at all of those. It is important. HPV is the most common STI in the United States and is responsible for approximately 70% of cervical cancer globally. There are approximately 14 million new infections yearly. And with tetanus, one case of tetanus results in 100% hospitalization, and costs can reach up to $102,000. So preventative care is cost saving versus treatment. So for the local problem at Lifespan, I did 20 chart audits as well as an electronic health record report. And we were only at 43% for annual well child exams. The HPV completion rate was 6%. With meningococcal at 29% and Tdap at 38%. We were not using evidence-based guidelines consistently. We had no process in place to engage our patients in their health care, and this was an issue causing some of these deficiencies. So children who are not immunized, of course, are at higher risk for serious illness and complications, as I mentioned earlier, with one case of tetanus can result in approximately $102,000 worth of treatment. The ACIP guidelines recommend HPV, Tdap, and meningococcal starting at 11 years of age. And there's a goal for Healthy People 2020 of 80% completion. Preventative care saves money and prevents the spread of disease, as we've seen recently with an outbreak of measles across the nation. So the rationale for this project, we used an SBIRT, which is screening, brief intervention, and referral for treatment. The screening of the immunization status and their annual well child exam was to be done prior to the patient being seen in the office. And then the intervention was to either give the immunization and complete the well child during that visit or to schedule it for a future visit. The Institute of Medicine domain that we used was Right Care, which is appropriate effective care while preventing overuse or underuse of medical care. There was a case management log that was implemented to track the completion of the Right Care bundle of these preventative services. And once again, like I said, we used the Advisory Committee on Immunization Practices guideline. The specific aim of this project was to increase well child exams and recommended immunizations in patients 7 to 12 years of age by 21% at Lifespan Health within a 90-day period. So we've done this with 4 PDSA cycles. We're at a federally qualified health center in rural West Tennessee. The team consisted of 3 providers and 4 support staff. The patients were, like I said, those aged 7 to 12, and they included uninsured, Medicare, Medicaid, private insurance. So the interventions, there were 4 core interventions, and these were done in 4 PDSA cycles of 2 weeks each. Screening checklist was the main one done prior to the patient being seen in the office. And then we implemented a patient engagement tool to help engage the patients in their health care. The case management log followed the IOM domain of Right Care to do the effective care. And then the team engagement was weekly QI team meetings. We also did a team huddle there at the end to help keep this team engaged and informed on what was going on. So studies of the intervention. We collected the data every 2 to 3 days on the pre-visit screening checklist use, the patient engagement tool use, and the Right Care components. We did a weekly QI team meeting agenda, and we did staff surveys, as well as there was patient comment section on the patient engagement tool. So the aggregate data was compiled onto spreadsheets, and run charts were analyzed for special cause variation, and we looked for corresponding trends or shifts to see the efficacy of each intervention that we tried during the PDSA cycle, which helped to guide the next intervention. So for the measures, screening, we looked at the total number of patients screened and the total number of patients that were eligible. Same thing with patient engagement. The case management log looked at 4 components. Had they had their annual well child exam? Had they completed their Tdap, their meningococcal vaccine, and their HPV vaccine? The team engagement, we looked at the scoring on the team meeting every week, and then we also did a team survey to see the team satisfaction. A balancing measure was put in place to make sure that this quality improvement project did not cause an increase in patient wait time. For the analysis, the quantitative data was analyzed 1 to 2 times a week. We looked at the completion of the screening checklist, as well as the patient engagement tool where the case management logs being completed. So the team survey comments would help guide some of the next interventions, as they included a Likert score as well as open-ended questions for the team to insert their comments. And then we also reviewed the agenda notes for comments that might have been made during the meeting. This quality improvement project was excused from IRB review, as this is a quality improvement project, and involved no patient research. And there were no financial contributions made. So on the results, as you can see, we did not reach goal on everything, but we did show some improvement. The case management log was utilized, 100% of the time, with a 66% completion rate, which exceeded our goal of 50%. The balancing measure was our goal was exceeded of 83%, and the goal was 75%. I'm sorry, yeah, my mouth is dry. So for the utilization of the pre-visit screening checklist, this was utilized 100% of the time from its implementation in PDSA 1 all the way through PDSA 4. We added patients we started out with screening patients that were on the schedule at the beginning of the day prior to them being seen in the office. So in PDSA 4, since we had 100% screening rate, we decided to add patients that were being added to the schedule during the day and screen those prior to them coming into the clinic instead of just those that were present at the beginning of the day. This continued at 100% rate. On the patients screened for immunizations, as you can see, we had an astronomical data point of 0% that we identified needed immunizations. We had some local catastrophic flooding that cut off, it caused school to be out for 2 weeks and cut off many of the roads, so patients were not able to get to the clinic and decreased our patient loads for the day. The median on this was 29%. And our goal was 75%, but we did identify that it's not necessarily a bad thing. This was identifying patients that needed immunizations, and so those that had reached it did not count for this. So on the case management log, as you can see, the flu outbreak caused a decline in completion rates because when patients are acutely ill, you cannot administer vaccines. One thing we did learn from this was that during flu season is not the time to implement a quality improvement project when you're trying to administer vaccines to children. We started some outreach calls, which had completion of the 10 patients that were included in that, which was an improvement. Our median on this was 58%, and we exceeded our goal of 50% completion rate. Sorry, it's going the wrong way. Okay. So in this pre-visit screening checklist, we screened 124 patients. 84 of those needed an annual well child exam and 39 needed immunizations. We contacted 54 patients on outreach, and we identified and tracked 135 patients that were deficient in right care. Our patient engagement increased to 80%. We went from 0 to 80%. And we had a 69% completion rate for right care. Team engagement also increased 37%, and we developed a sustainable process improvement. So for the interpretation, we developed standardized screening. We do this prior to the patients being seen in the office. This helps to reduce missed opportunities. In the 7 to 12 age range, research has showed that these patients are perceived as healthy and do not routinely come into the clinic for a well child exam or immunizations unless they are required for school attendance. The patient engagement tool helped to find out what the patients were concerned about, and they were able to complete this form prior to being seen by their provider, which helped to guide their visits and cut down on visit time, actually. So the case management log was a way to track the patients that needed right care for those that did not receive it in the office that day and were scheduled to come back at a later date. It provided for reminders to be sent to patients and outreach phone calls to be made. Team engagement improved throughout this whole process as the team was very energetic in learning something new and being a part of this. And we did some role plays, which helped to increase their comfort measures when discussing things such as the HPV vaccine, which was our lowest measure. In the cultural context of the rural South, this vaccine has not been very well received. So the limitations, we had a small team size, which allowed for personal attention. It allowed for everyone in the office to be on the same page. We worked as a team together. Staff training, if once this is spread to a larger population, this could result in some decreased reliability of the screening, as it will be harder to oversee did everyone get screened as appropriately, and the reliability can be affected. The patient health status can also affect this. This was during a flu outbreak, and then, like I said, we had the localized flooding, which affected a lot of our numbers. So for conclusions, screening increased 100%. We have an effective and sustainable process that has now been standardized and has been spread to the other clinics. The next step would be to continue the utilization process, as well as continuing to monitor our completion rate for the right care components, and to outreach those patients again in a year for their next annual well child exam. Future studies could also include expanding this to other age ranges, to include other immunizations, as well as other areas of prevention, such as colorectal screening and diabetics with A1Cs, foot exams, and eye exams. This is generalizable to all these other healthcare preventatives with the screening, the patient engagement, referral, right care. These are my references. And back to school time is a great time to work to process immunizations and to do an ad campaign. So I would like to thank you all for taking your time to watch this. And does anyone have any questions? All right. Sorry, guys. I get tongue-tied and then.
Good.
Nice job, Nicole. You were right at about just under 14 minutes.
Okay. And like I said, my mouth is dry because I've taken so much Imodium today. Oh, not to mention not much sleep last night. So,
Yeah.
Well, and to talk for 20 minutes continuously like that dries up your mouth.
It does.
And I said I have a lot of practicing to do on mine. So
I thought you did a really good job.
Yeah. I liked how you, several times in the beginning, you specifically said what your right care was. Like, specifically, we're measuring these specific vaccines, these well child checks. It was very clear what you were actually looking at. I thought that was really good.
And I try to, because that was one thing Dr. Butler said, is most of my information, because there's so much out there on HPV and the cost of it and what it's responsible for.
Oh, you froze.
Nicole?
You guys lost her too. There you are.
I'm here.
Nicole? Oh. Go out and come back.
Right. Nope, we lost it.
Is that her feedback?
Is what?
Do you hear a little bit of feedback, or is that just me? It's not there now. I'm losing my mind.
Of course. For a minute, I thought maybe I did hear something, but then when I listened, I didn't like, eh?
Okay, now I don't hear anything.
Now I do. I hear that.
Yeah. Okay.
Like TV in the background. Yeah. Oh, Sarah, I've missed you.
When I saw that you were going to be on this today, I was like, oh, those were the good old days.
All
We
right.
had a policy together, and we had the best group.
We did have a good group.
Also, so glad I'm not taking it right now.
Oh, I am too.
Two.
All right. Nicole, can you hear us?
You back?
Maybe. Oh.
I hate that because it's with their feedback. Like, this is what you want to hear. Like,
I know. I know. Okay. Hey, Jenny, were you affected by all those tornadoes?
I personally was
flooding.
not. No, I personally
Okay.
was not.
Okay.
Yeah. And in fact, people are like, oh my gosh, we had all these tornadoes last night. I'm like, oh, we did? Because I just feel like this time of year, they're all the time. And I just get up
All the time.
We had tornado warnings here in Colorado, like in my neighborhood, which I live in Metro Denver. And we were like, do sirens go off? What are we supposed to do?
Really? A tornado in Colorado.
They had 9 touchdown on Sunday.
Wow.
Like around on the outskirts. And then yesterday we had like softball size hail at the airport, and they shut down the airport for like 10 hours.
Wow.
Yeah.
I feel like probably more so we've been affected by flooding. Like there's whole highway closed because it's underwater. So that, in addition to tornadoes, has not been good for the people who have been hit.
Yeah.
Bethany, where are you at?
I'm in central Indiana. So,
what are you guys having right now?
Well, we had tornadoes yesterday. And so they were all kind of northeast of me. But I mean, we were under a warning last night, but nothing hit by me.
Did you guys get any of that crazy snow that we got last week?
No.
Well, we got a ton of snow last week.
Yeah, I've seen pictures. I have friends. Yeah, I have friends that live out in Colorado, and they're like, "Oh, here's our blizzard." I was like, "It's almost summer."
Yeah. Like I literally was wearing shorts like 2 days before.
Wow.
I still love it though. I still get excited when it snows. So I'm probably the only person here in the city that was excited that it was snowing. Everybody else was, walking around grumbling at work. Oh, it's gonna snow, and I was like, yes.
All right.
Love it.
That's funny. All right, Sarah, do you want to go ahead and start, and then if Nicole gets back on, we can finish up with her.
Will she be able to join back in on that same invitation, or should we?
I don't think so. I can.
I think you can. I got accidentally shut my screen down, and I was able to just click it back on.
Okay.
Yeah, I resent it to her just in case. So hopefully she can jump back on, and we can finish her feedback.
I really need to figure out how to
say everything
before slideshow. There we go. Okay. So hi and welcome to my presentation on improving merit-based incentive payment system measures using effective care and standardized processes in a retail health setting. I'd like to thank you for everybody who is in attendance today. This is a photo of part of my amazing team, Samira, my PCT, and I outside of our clinic. So why is MIPS important? Merit-based incentive payment systems, or MIPS measures, are a requirement for nearly 60 million Americans who have Medicare or those with additional payer systems that are now adopting this practice. MIPS focuses on 4 metrics: promote cost efficiency, efficient care processes, to improve health outcomes and patient engagement. This year, there will be up to a 9% penalty for non-compliance with established measures, which can result in millions of dollars to the little clinic alone or other organizations. In the planning phase, 20 chart audits showed these top 5 MIPS measures with non-compliance: influenza and pneumococcal vaccination screening and documentation, smoking cessation, high blood pressure education, and documentation of advanced care planning. Through patient surveys, 95% of patients wanted to take an active role in their health, but only 55% felt they had enough information to make appropriate decisions. So what do we know? The Center for Medicare and Medicaid requires MIPS for all people with Medicare Part B. This is roughly 10% of the population served in our clinic alone. One study completed noted modest effects in primary care outcomes and quality of care for patients with MIPS compliance. Using CMS guidelines, the little clinic has 10 measures that they focus on. The ones with the greatest need for improvement were mentioned on the previous slide. The rationale used from the Institute of Medicine's aim for effective care, which is based on providing appropriate services using scientific knowledge when warranted. This, combined with the CMS requirements for each measure needing improvement, was the foundation of this project. The aim of this quality improvement project was to improve identified MIPS measures using pre-visit screening and documentation for patients 18 years and older seen in a retail health clinic to 75% within 90 days. The Little Clinic is a retail health clinic located inside of King Super grocery store in the suburban city of Wheat Ridge, Colorado. The 2-room clinic serves 25 to 35 patients a day from surrounding neighborhoods up to an hour and a half away. Patients were primarily Caucasian at 95% and insured by private insurance, Medicare, Medicaid, or self-pay. The clinic is staffed daily by a provider and a patient care tech with a total of 2 providers and 2 PCTs for the clinic to split a monthly schedule. The project was structured as a rapid cycle quality improvement project using 4 Plan, Do, Study, Act, or PDSA cycles. Each PDSA cycle was approached with small tests of change applied to 4 core interventions every 2 weeks. The tests of change were a pre-visit screening checklist, shared decision aid, audit and feedback log, and team huddles. During the planning phase of the project, I collected baseline data using chart reviews, a gap analysis, and patient and team surveys. During the 4 PDSA cycles, data was collected twice a week and entered into Excel spreadsheets. Using the 12 spreadsheets and data exported into subsequent run charts, I was able to evaluate my data for any shifts or trends I was seeing, and this influenced all of my future tests of change. For each of these measures that we selected, there was a process and outcome measure. Measures were focused on the screening tools used with the gaps of care identified, how many patients used the shared decision aid and chose vaccination, documentation on gaps in care, and percentage of documentation completed. And lastly, if any of these tools had an adverse effect on the overall visit time. The quantitative data collected and plotted allowed for visualization of the progress with each test of change and how it corresponded with the outcome measures. Upon completion, run charts were assessed for any identifiable shifts, trends, or common and special cause variations. Qualitative data was collected from the end-of-day surveys and candid patient feedback. This doctoral project was excused from review by the Institutional Review Board at Frontier Nursing University because it does not qualify as human subject research and meets federal requirements for quality improvement. And no outside funding was received for this project. Our aim was to improve screening and documentation to 75%, and we exceeded this by achieving 98%. Huddles were overall successful with the majority of huddle items covered and improved end-of-day surveys to 78%. We were successful in using our pre-visit screening checklist on 98% of our patients, with 48% of patients found to have a gap in care. The shared decision aid was used for 91% of patients and 29% chose vaccination in the end. The audit and feedback log validated our hard work with 99.8% documentation completed and 54% of those patients had gaps in care that were addressed during the visit. The average daily visit time only increased by an average of 1.1 minute throughout the project and was not significantly affected by these tools. This is my process, This is my process measure run chart for the daily huddle tool utilization. Ultimately, when 2 team members were present, huddles were performed and items on the agenda were collaboratively addressed. Our greatest success on this measure was in cycles 3 and 4 with consistent attendance of all team members, and we were able to achieve 100% compliance. The pre-visit screening checklist assisted in identifying gaps in care to be addressed during each visit. Gaps most commonly found were smoking cessation, influenza and pneumococcal vaccinations, advanced care planning, and a current medication list. You can see the highest points noted on the run chart were found to be with a high patients with no influenza vaccines, and our project was performed in the height of influenza season. This chart is the outcome measure run chart for the pneumococcal shared decision aid. Patients were identified using the screening checklist and then addressed during the visit. Many patients reported enjoying the content of the shared decision aid, but were unable to commit due to current cost or illness. Patients found to be candidates were primarily self-pay and had trouble justifying the $200 for the out-of-pocket cost for the pneumococcal vaccine. After finding so many patients on the screening checklist without influenza vaccinations, a second shared decision aid for influenza vaccinations was implemented and had increased success in overall vaccinations. Sorry, I just got Nicole's message. I was worried I cut out or something. So you can see that I had a positive trend after implementing the shared decision aid for the influenza vaccines. This bar chart is for the process measure for the audit and feedback log. Here you're able to see the trends in the gaps in care that were documented on. The influenza vaccines were the most common documented gap, and this decreased after the implementation of the influenza shared decision aid. This graph also represents the impact of each patient, the focus of preventative measures, even though the majority of the patients are not presenting for anything relating to that. And by documenting on each measure, we can increase the reimbursement for our organization. This slide specifically just felt really impactful to me in what we're truly achieving with this project. To recap, the aim was to improve screening and documentation to 75% compliance, and through the project, we improved from a baseline of 40 to now 98%. Team engagement improved by 27%. Overall, the team reported this was an effective intervention despite some initial attendance issues. The screening checklist had 99% compliance and screened 316 patients. The shared decision aid had 29% of patients choosing influenza or pneumococcal vaccinations in the end. And the audit and feedback log had the 99.8% compliance and validated the gaps in care. However, the time commitment was such a hindrance that I don't believe this could be continued. Improved communication and team engagement contributed to improvements throughout the project. Literature found was congruent with findings we experienced, which were daily team huddles, improved efficiency, and decreased surprises throughout the day. The checklist was well received by both patients and team members and spurred the overall success of improving MIPS measures. It ensured standardized screening for each patient, and gaps in care were addressed during the visit. I had been concerned patients would be upset with filling out the form, but this turned out to be a great diversion for patients while waiting. The patient care tech also appreciated the section for the patient to write the chief complaint down, therefore keeping patient personal information private. The checklist allowed for easy identification of patients to use the shared decision aid, and the majority were receptive to the information provided. During discussions with the patients, multiple reported feeling empowered in their healthcare decision and enjoyed the collaboration with the provider. This experience closely aligns with research found that emphasized the importance and success of shared decision making. The shared decision making has also been found that patients were more likely to follow through with their decisions. The overall cost of implementation was roughly the cost of a package of printer paper. I would say overall this cost is considered minimal with the 316 patients that were screened, had gaps identified, educated, and documented on, and how that would translate into our overall reimbursement. Limitations identified are tools that are currently created for the retail health clinic structure and our identified measures. The small team size could also limit the validity of the project when compared to the TLC network, which is roughly 450 providers. While they were easily implemented within our clinic, the desire to use the tools can be limiting throughout all the clinics. Fortunately, they can be easily modified to be standardized screening tools, and generalized for numerous other settings. We improved MIPS measures using evidence-based practice and hard work. The screening tool allowed for easier documentation for providers, the opportunity for patients to be more engaged in their care, and identify potential patient risk factors. The vaccination shared decision aid streamlined the process for identifying patient candidacy, assisted them with options to decide, and optimally improve vaccination rates within our community. Further study of the influenza shared decision aids effectiveness due to late implementation and how well these tools would be scaled to additional clinics would be important. And the overall improved teamwork and communication resulted in better workflow, enhanced efficiency, and positively impacted the patient experience. So these are my references and my questions. Thank you so much for attending and all of your support. You ladies are awesome.
Yay. Good job.
Yay! I finished.
Yay.
And you were,
Slideshow.
yeah, you were just over 13 minutes, so nicely done.
Okay.
Good
I
job.
got a lot of practice to do.
Me too, Sarah. Thank y'all. Sorry, my internet just went down. It's been doing that a lot since I moved. So,
Well, we're glad you got back on. We waited for a little bit.
well, I had to restart my computer and I got my video off so it doesn't use as much on my hotspot till my internet comes back on.
Yeah. Okay. All right. Just think, now you can all say that you've gone through your presentation at least once.
Check.
Right,
My nurse has offered to Friday afternoon, because we don't see patients on Friday afternoon, to let me practice with her several times. And my daughter's coming over this weekend, and that's what she said. She'll just do what she can to stay awake while I go through it several times.
Very good. Very good.
All right. Sounds good.
Sarah, I liked how you that last graph, the last chart that had kind of those overall that you said was really impactful. I agreed. When I saw that, I was like, wow, it was an awesome. And the fact that you acknowledged that you felt it was impactful, I really liked that you did that.
Thanks. You ready, Bethany?
All right. I am. All right. Good morning, everyone. Thank you so much for attending my final DNP presentation. Please enjoy lunch while I discuss with you effective screening and treatment for perioperative hypothermia here at Indiana University Health, University Hospital. I want to personally thank Erin Wilson, who was my sponsor, and Kim Pilecki, who was my mentor, as well as all the nursing staff, anesthesia staff, and support staff among the pre-op, OR, and PACU. Perioperative hypothermia affects at least 20% of surgical patients. There have been studies published this year that state that the incidence is much higher than previously thought. Mount Sinai did a study that showed patients who stayed in PACU for an additional 2 hours cost the hospital and patients an additional $700,000. Patients who experience hypothermia had increased risk for surgical site infections, pressure ulcers, and delayed wound healing, which can also increase patient costs and length of stay. Last fall, I performed chart audits and identified that 37% of our patients were hypothermic at some point during their perioperative experience. Of those patients identified, 85% of them experienced a delay in being transferred out of PACU. While we also have no formal screening or tracking, and there were no standards or guidelines for preventing or treating perioperative hypothermia. Perioperative hypothermia remains a national top priority and is a part of the Surgical Care Improvement Project. There are several professional organizations looking at and researching perioperative hypothermia. In 2010, the American Society of Peri-Anesthesia Nursing published the evidence-based clinical practice guideline for promotion of perioperative normothermia. But the greatest downfall with these guidelines, which can be seen here at IU, is that these guidelines were meant to be recommendations and not standards or requirements to be utilized in perioperative settings. These recommendations are being used at the discretion of each healthcare institution. The framework utilized in this project was adopted from the Substance Abuse and Mental Health Services Administration for screening, providing brief intervention, and treatment, which is known as the ESPERT model. This particular framework is ideal for quality improvement projects because it uses an early identification approach to identify, reduce, and prevent conditions like perioperative hypothermia. The ESPERT model was combined with effective care, one of the 6 aims for healthcare quality of the Institute of Medicine. I also used a shared decision-making tool to improve patient feedback and satisfaction. And lastly, I used the Steps Forward Team Huddle template to help bridge the gap between team engagement and communication. The specific aim of this project was to improve effective screening and treatment in 80% of patients for perioperative hypothermia over a 90-day period. University Hospital is a large adult academic medical center that specializes in cancer treatments. There are 16,000 procedures that are performed annually. We have 30 anesthesia attendings, around 75 surgeons from a variety of specialties, hundreds of residents and medical students, 75 nurses between the 3 departments, and several support staff. This was a rapid cycle quality improvement project that utilized 4 plan, do, study, act cycles, each lasting 2 weeks. During each PDSA cycle, 4 different tests of change were congruently implemented and evaluated. These are the 4 core interventions. A screening tool started in pre-op with the patient's initial temperature, and then the screening tool followed the patient to the OR and PACU for those initial temperatures. If any of the temperature fell below 36 degrees Celsius, the patient would be entered into the case management log and tracked to ensure right care treatment. Patients were given a shared decision-making tool by a guest relations specialist, and then the tool was discussed with the patient by a pre-op nurse. Finally, team huddles were done by the charge nurse or shift coordinator, and then at the end of each cycle, a team huddle effectiveness survey was given to the team members to complete. Quantitative data were collected from each of the 4 interventions every 2 to 3 days, with the exception of the team huddle effectiveness survey, which was only collected once per cycle. The aim and balancing measure data were collected every other day. Qualitative data was also gathered from patients and team member feedback. The data was then entered into Excel sheet as aggregate data and then applied to run charts. The run charts were studied and interpreted continually for trends, shifts, and correlations between the intervention and outcomes to determine if improvement was actually occurring. Small changes were made to each intervention based on the results of data, feedback, and suggestion from team and patient. These were the operational definitions used to help determine improvement. All the tools used measured rates of utilization. The team survey was scored using a Likert scale, and the averages were taken of the survey responses and on the patient engagement tool. The aim was the average of utilization of the screening tool and the case management log, and the balancing measure was the rate of bear hugger utilization. Quantitative data was collected and analyzed every 2 to 3 days. Run charts were continually analyzed for trends, runs, and shifts at the end of each 2-week cycle. This project was exempt from the Frontier Nursing University IRB because it did not meet, it met federal requirements for quality improvement and was not research on human subjects. And there was no outside funding received for this project. Here is a graph of my results. As you can see, we did not quite meet our goals, but what is impressive was our improvement overall. The aim, which was the screening and treatment, improved by 64%. And then our team huddles, I have each individually listed here by department. The greatest improvement was seen in our pre-op area, Our patient engagement tool, our patient engagement fell a little below what our baseline was. The screening tool increased or improved by 61%. Right care treatment improved by 68%. And while our utilization of bear huggers decreased by 2%, we still remained above my goal of 90%. Here is my run chart for my AIM, which is the perioperative screening and treatment. As you can see at the beginning of the project, there was some lack of motivation with our team members, as well as lack of consensus on what guidelines should be for treating of perioperative hypothermia. And once we decided what the guidelines should be, as well as I ended up scaling back on my project and ended up only screening 3 anesthesiologist patients in PDSA cycle 3, we had the greatest improvement. And then in PDSA cycle 4, I added 2 more anesthesiologists to that patient mix. Team engagement is a key influencer to process changes. Without team engagement, screening tools would not have been completed and treatment guidelines would not have been established. My next run chart is hypothermia identified between our pre-op, OR, and PACU. As you can see, it's kind of all over the place. At the beginning of the PDSA cycle 1, our screening tool wasn't actually being completed. pre-op had some confusion as to who got screened. And then once we moved those screening tools to actually the unit secretaries, placing them in the patient's charts, then the nurses were starting to fill out those screening tools. But then the next problem was for the next department to fill it out. But then by the end of PDSA cycle 3 and 4, my nursing team kind of got on board and we ended up having a nice positive trend toward the end. So many of the screening tools were incomplete in the first half of the project. Once the project scaled back and key team members were identified, screening rates improved, leading to better identification outcomes. This chart, even though it looks really messy, is actually one of my favorites, and it is the utilization of our team huddles. And team huddles were done 4 times a week, and the OR is in the light blue, and then pre-op is in the purple, and PACU is in the yellow. So it looks confusing. However, OR stayed pretty much maintained around the 80 to 90%. Pre-op kind of had some fluctuation, and it was likely due to being too busy to huddle in the mornings. But overall, they had the greatest improvement of team huddles. And PACU kind of struggled once they were implemented in PDSA cycle 3, kind of getting on board to doing those huddles. When team huddles are being utilized, teamwork and communication does improve. And this is also one of my favorite graphs. And what this shows is these are the questions that I had asked our patients to fill out about comfort measures. And then I scored, this is the average of answers. And towards the end of PDSA cycle 3, I reevaluated the questions for better clarification. And then in PDSA cycle 4, I ended up dropping 4 or 5 of the questions because they scored less than 50% on the tool. So I took those off entirely. And some of the questions that I left on here, even though they scored low, were pain medication and pain rate, as well as anxiety. Because when I did my initial screening before implementation, those were scoring high, and then once implementation started, they ended up being low scores, which I kind of thought was interesting as patients were waiting to get surgery. Leading on to discussion, screening and treatment improved by 64% over 90 days. 30% of patients screened were identified with hypothermia, which was a decrease in 7% for the baseline. Right care increased from 0 to 68%. The key strength and success of this project were the great strides made in teamwork and communication, especially in our pre-op area. Huddle utilization increased by 67% and communication improved by 10% in that department. Many of the components used in this project can be generalized to other surgical settings. Stewart and Johnson wrote that huddles are used as a tool to strengthen communication and teamwork.
There were positive association and correlations between huddle utilization and communication, as well as between screening and identification. Despite what literature will say, huddles may not be appropriate in all settings. I experienced this from our PACU department. They had the lowest huddle utilization rate and the lowest effectiveness scores. The impact on the system is threefold. First, I have proposed new guidelines for hypothermia. Second, a new standard has been proposed in our pre-op department based on patient feedback. And third, there has been a culture change, especially in our OR, with hypothermia awareness. There were some limitations noted on this project. Our unique patient population and clinical setting specializes in cancer treatments, and results may vary in a different setting with a different patient population. The patient engagement tool was specifically designed for this project. Another limitation concerned the number of providers included at the beginning of this project. In an effort to mitigate this flaw, I scaled back the number of providers, which allowed for more completed and accurate data, and it resulted in huge momentum shifts during cycles 3 and 4. In conclusion, this project demonstrated efforts of effectively screening and treating 64% of patients for hypothermia. Following this project, new guidelines and standardizations have been proposed to clinical leadership to help guide and mitigate perioperative hypothermia and make these efforts sustainable. Additional sustainability can be achieved through the continued use of team huddles, which has been proven to improve team engagement and team communication. Thank you for coming to this presentation, and here are my references. And then here are some more awesome members of my team. And thank you. Anybody have any questions?
I still cannot believe you started with that many providers.
I know. It's ridiculous.
I used to work in the OR in a rural hospital, so a much smaller scale, and I could not imagine trying to track it in that many, much less what you did.
That's ridiculous. So I would have to say, I mean, I had fantastic data. So I screened over 300 patients, and over 180 patients completed my team engagement tool. So I had great data, but it was just so large and it was so big, and
I would definitely kind of, and when you talk about how you scaled back, I think I would point out that part of, because it was a rapid cycle, that it was not feasible to have that many people to try to get on the page and do it that rapidly. So I would really bring those to the rapid cycle with that number of people. Wasn't feasible.
Yeah. It was just ridiculous.
That's a good point.
Do you want to end
my question? Would you really? But good job. Good job.
Dang.
Yeah.
That was awful. I feel like that was awful, but
no, it was good. It was good.
So you had notes on your PowerPoint, but we didn't see them. Are you going to be able to do that for the big presentation or not?
What do you mean she had notes and we didn't see them?
Didn't you have a notes section on that last slide when you minimized it or not?
I did.
But you couldn't see it when you were presenting either, could you?
No. So when I presented, it was full screen. So I had my notes next to me, I just
tricky. I want to know how to do that.
No, when I was presenting, it was full screen and I couldn't read my notes. There were no notes to be had.
Well, thank you.
So yes. So yes, my husband's gonna get really old of this presentation over the next 2 weeks.
Like I said, my daughter's coming this weekend. I've had to bribe her. So.
Yes.
My dog doesn't give much feedback, and that's the only other person here. So
yeah. Well, and you guys too. I remember because I know I did this with my, and I'm gonna keep it, I think, forever because it just cracked me up so much. But when we had to do those, I don't know, those little elevator speech.
Oh yeah.
Your stuff in 30 seconds or something. Well, I recorded mine, and I have and I would name it, and I would be like, okay, take 4. Like 29, and like literally it was like on one of them I would start and like, damn it.
Yep.
But it's like, so I think to remember that we can record ourselves and watch it back to see, because it looked like we're making eye contact out there is for me was very, very helpful with that.
Yeah.
And it cracked me up too. But
That's a good idea to do that. I hadn't thought to record myself doing it.
Oh,
okay, so Bethany, you'll send out this link.
I will.
And we attach it after we do our presentation to our reflection and our
Attendees list. Yeah.
Are we still recording or have you stopped?